Hi, my name is Melissa Barajas. I'm the Director of Population Health at Neighborhood Healthcare. We are an FQHC located in Southern California across 2 counties, San Diego and Riverside. We have 11 health centers, 10 of them with adult primary care, and we see about 65,000 patients annually. So I'm going to talk to you about the operational efficiencies in colorectal cancer screening. This is our UDS CRC screening rate system-wide. From 2015, we had a screening rate of 46%, and if we dated even further back to 2013, we were only at about 17%. For 2016, we increased our CRC screening up to 54%. And then we took it even further and did some internal neighborhood healthcare data. So those of you familiar with UDS includes every patient who's been to your health center once within the past year. So we factored out those patients who are inactive, they're deceased, they're no longer assigned to neighborhood health care, or they've only come in for urgent care or behavioral health only, but they have a primary care provider outside of neighborhood health care. So when we factor those patients out, we actually have a 60% CRC screening rate. So we partnered with the California Department of Public Health and Screen for Life in a program funded by CDC to improve and implement changes to our CRC screening policies. So our scope of work includes establish a provider care team reminder system, establish a patient reminder system, reduce structural barriers to CRC screening, establish a provider care team assessment and feedback system, improve ability for the health system to track CRC screening by enhancing the measurement and use of health system data, and then increase community clinical linkages that support improved access to CRC screening. So in the next couple of slides, I'll go over how we've accomplished each of these steps. So establish a provider care team reminder system. So on the left-hand side of your screen is a snapshot of our policy that we implemented. And the right side of your screen is our alerts application. This sits on top of our electronic health record. We use eClinicalWorks. However, this alerts application is not an eClinicalWorks product. It is something we developed internally to be an add-on application. It links to our patient. In this case, it's a test patient, and it displays all the care gaps. All the preventative services that a patient happens to be due for. So because this is a test patient, it looks like they haven't had anything done, but in a live patient case, there would only be a handful or 1 or 2 items in red that indicate the patient needs that service done. So circled in there is CRC, and you can see this patient has had none, so it says none, and then pending none. So what you would see in a real life patient is you might see the last fit test date, and then if they're due again, if it's been over a year, it'll highlight red, or if they've had a colonoscopy, that will also display on there as well. So it's a way for the provider and care teams to know that a patient is due for CRC screening. So I'll read through the protocol real quick. So between 50 to 75 years old, colonoscopy every 10 years, or FIT every year. So we do offer both. We tend to focus more on the FIT testing. We tend to emphasize that, but we also offer colonoscopy. We use the alerts application to determine if colorectal cancer screening is needed. And I should step back. This is actually for our medical assistants. Our medical assistants are the ones under this protocol, under the provider oversight. So the medical assistants are the ones actually using the alerts app to determine if the patient is due for CRC screening. If needed, ask if they had a colonoscopy in the past 10 years. If yes, document historic colonoscopy. And then they actually order the records because we can't count colonoscopy as being completed unless we have the actual record in our chart. So they actually request that. They have the patient sign the record release, and they create an action to follow up with the specialist office for records within 1 week. So action is something that's within eClinicalWorks, and it's a task. It's a way for medical assistants to task themselves with a certain item pertaining to the patient. So they create an action for themselves so that they can follow up within 1 week. They select the action type of care coordination and the subject of colonoscopy records. So if they're unable to obtain the records, and this happens frequently for us, especially if the colonoscopy was done at a center that didn't have electronic medical records, or maybe the patient forgot and sent to the wrong specialist, we just get them onto the FIT route. So we order a FIT. If the colonoscopy was completed 5 or more years ago and patient isn't sure of where it was completed, again, we just order the FIT and we get them on that game plan. So after ordering the FIT, we instruct the patients to return the FIT kit as soon as possible. And we include FIT kit instructions with the FIT kit, and we verbalize those instructions to the patient. We ask the patient if they are able to return to the clinic to drop off the test. And if they're not, if transportation is a barrier, which it is for most of our patients, we supply them with a pre-stamped envelope, and we verbalize instructions on how to mail that FIT kit back to us. We also pre-label the FIT kits with the patient's name, date of birth, and a space for the patient to write their collection date. We've actually gotten samples back where they're not labeled. The patients forget to write their name, or they forget to write their date of birth. So we take care of that step for them. And the MA who gives the FIT kit, they create an action in eClinicalWorks to follow up on the FIT kit in 1 week if it's not returned. And again, this is just saying how they select an action type and the subject of FIT reminder. So part of establishing a patient reminder system is, this is continuing on that same exact protocol. The MA who gives the FIT kit creates the action, and on a daily basis, they track those patients who have received a FIT kit and place reminder calls to patients who have not returned the FIT kit within 1 week. So those actions in ECW are really nice, and there's actually a screenshot of that towards the bottom of the screen. You can select whatever you're calling the patient for. You add in your notes of calling the patient, spoke to the patient, and whatnot. You can make it a recurrent action. And you can select how often this action pops up in your EMR when you have it open. So if they want to follow up on this in 1 day, 2 days, 3 days, 1 week, whatever time frame, they can have it set so that it reminds the medical assistant, and then they in turn will take action on it and call the patient. And if the medical assistants are unable to reach the patient, they notify patient care coordinators to continue outreach. So our patient care coordinators are staff who are also medical assistants but have been trained on motivational interviewing and just a little more hand-holding that they can provide the patients, because at this point there may be a motivational issue to why the patient doesn't want to return the FIT kit, or other barriers that they can explore further. So to reduce the structural barriers to CRC screening, we picked our most frequent barriers, which were the educational material that was given and the instructions that were given to the patient. So historically, they were all written down, not always available in the language of their preferred language. So we decided to implement a visual instruction that is easier to understand. It has, it's wordless for the most part. There's just a little bit of verbiage at the bottom, and we translate that into their preferred languages. We also implemented a drop box in the lobby of all waiting rooms so that the patient doesn't have to wait in line or make an appointment to drop off the kit. They can simply place it in the lobby. And we also found that transportation, I mentioned earlier, was a huge barrier for most of our patients. So we provide a pre-stamped FIT kit return envelope if transportation back to the clinic is a barrier. To establish a provider care team assessment and feedback system, we, as part of this scope of work and something we implemented prior to joining on this grant, was the Colon Cancer Quality Incentive Plan. So a bonus of $25 per month per measure will be paid to the support staff at each site if the site reaches a predetermined goal set for each specific quality measure. So the support staff mentioned here includes the medical assistants, the patient care coordinators, our medical records staff, our front office staff, our referrals clerks, our lab staff, as they are all partaking in ensuring the success of our patients getting their CRC screening completed. So the two measures we use are colon cancer screening rate incentive applies when a site progresses from one 5% interval to the next. So for example, if the site is at 40%, once they reach 45%, they receive that bonus for the month. The fit test return rate incentive applies when a site achieves a 75% return rate for the month. 3 months, we do a 3-month look back from the reporting date. So they have 3 months, the past 3 months, to get at least 75% of their patients to return their fit test, and they will receive the bonus. So improving the ability for the health system to track CRC screening by enhancing the measurement and use of health system data. This is a screenshot of some of the reports, automated reports that we've built internally. So this displays all of the providers and their care teams and their percentage for CRC screening. So it goes from highest to low. The two that have 100%, it's most likely when they just have 1 or 2 patients in their panel, so it's not a true measure in some cases. So we really look, if you look at the provider with 78% onward, and as you scroll down, you would see the percentage of each provider. And then the boxes on the right side indicate number of patients in need. So the larger the box, the more patients you have that are due for CRC screening. And a lot of the times these providers have really large panels, so that's why they have so many patients due for CRC screening. Not that they're not addressing it, they just have larger panels. This is more screenshots of our data. So we have our fit return rate per site and our CRC screening rates on the bottom per site. So this is a way for the sites to know how they're doing on CRC screening in comparison to other sites. Another screenshot, more drill down on the data. So this is specific to that quality incentive I mentioned earlier. These are the fit incentive specific data. So you see there the site's return rate. The next graph shows received versus ordered. So how many fits were ordered and how many have been received, have been returned, and then number to get to goal. So this only displays for the site if they have not reached their goal yet. So our Palma site has not reached their goal in this example, and they just need 3 more patients to return their fit test, and they will reach their goal. And then on the right side, this big black bar over any patient identifiers, this actually lists out the patients who have not returned their fits yet. So this is a way for staff to be able to go in there, see who hasn't returned their fits yet. Despite the system we have in place, sometimes patients do fall out, and so this is a way for them to catch them and to see who hasn't returned them, call them, get them back in, get them to return the fit or return it via mail. We also implemented visual management boards. So this data, it's live in our system. Everyone has access to it. But it's not always, people don't always go in and access it. They don't always go into the link, go into the graph. So we started printing them out at each of the sites. We print them out and display them in an area where all of the staff can see it, usually by the break room, and it's a way for sites to know where they stand, and this is updated on a monthly basis. So next is our referral process for abnormal fits. So these are screenshots of eClinicalWorks in the process. So the first screenshot is the lab results, and you can see it's ordered. If it was positive, a referral is generated. So within 1 day, a referral is generated, and that's pretty consistent throughout our organization that we address it within a day of a positive fit. We refer for colonoscopy. It takes about 2 months for a GI consult. So we have specialist GI consults under contract with our different health plans. So we refer them over. So it takes about 2 months for that to happen, and then usually about another month for the colonoscopy to happen. So in the perfect scenario, we get our patients who have a positive or abnormal fit to a colonoscopy within 3 months. Unfortunately, we have a lot of challenges that where this doesn't always happen within 3 months. And we started tracking the abnormal fits and colonoscopy to try to reduce some of the barriers that we have for our patients getting a colonoscopy done after an abnormal fit. So this is a screenshot of the tracker that we're using to make sure our patients get this colonoscopy completed when indicated. Abnormal fit tracking and colonoscopy continued. So in January 2015 to June 2015, we had a GI referral rate after positive fit at 87%, and a diagnostic colonoscopy after positive fit completion rate of 57%. So of the colonoscopies completed, of the 144, 25 of them completed within the 90 days. So, and we had an average of 190 days to complete. So we have this huge range between patients getting their colonoscopy completed after an abnormal fit. And in January 2016 to December 2016, and this was based on that tracker I shared in the previous slide, so these are all the manual reports at the grant-funded site. The GI referral rate after positive fit, we moved that up to 100%. So 100% of the time, we're ensuring our patients get that GI referral after a positive fit. The diagnostic colonoscopy after positive fit completion rate is only 14%, but we suspect it's higher. We have challenges getting the records, so we can only count it as truly complete once we have the colonoscopy records. So we suspect that there are just records still pending to get to our health center. So we suspect that's a higher rate than 14%. But of those 56 that we know were completed, 33 were completed within 90 days. 8 cases of polyps and 1 case of positive CRC that we caught early. So these are the challenges with getting the colonoscopy completed after a positive fit. Workflow process variances, so it's either the PCP that generates the referral, sometimes the MA calls the patient, sometimes the referral coordinator calls the patient, sometimes the care coordinator calls the patient. So the workflow varies across the site, creating barriers within our own system. Patient education is not always very thorough, so they don't understand why they need to get the colonoscopy done. Getting records from our GI specialists, I mentioned that earlier, there's sometimes a delay there. Long wait lists with GI specialists and difficulty navigating their system. We have, since they're outside specialty, we don't have control over how they schedule and whatnot. So, and sometimes they don't offer translation services either. So our patients have difficulty. So we've offered 3-way calling. Our care coordinators actually do a 3-way calling to assist the patient in making the specialist appointments, getting questions answered, and translating. Sometimes we have a vulnerable population. Sometimes they fail their prep. They don't quite understand it, and unfortunately fail the prep and then have to reschedule. And so sometimes they reschedule so many times and it just doesn't happen, not showing up to a specialist consult or not even showing up to colonoscopy day. Sometimes we're unable to reach the patient at all, and sometimes their emergency contact isn't even valid. We're not able to reach them that way either. Or our patients switch to a non-neighborhood health care primary care provider, which happens quite frequently. And some patients will still refuse even after education by multiple members of the care team, even by their provider. We utilize those motivational interviewing techniques, but sometimes they are unsuccessful, unfortunately. So the next steps for us is some process improvement development for the abnormal fit to colonoscopy. So at least streamlining our processes so that it's efficient, and also developing stronger partnerships with our GI specialists. Expanding our data dashboards to include the abnormal fit to colonoscopy. So if you remember, I showed you an Excel tracker to track this process. We haven't yet created data dashboards around it. Retrain our medical assistants on education given at the fit distribution. So we actually already did this. We included in the scripting that our MAs, when they give the patient a fit, to say, if it's abnormal, you will be referred to a GI specialist for colonoscopy. So previously to implementing that, our patients were just unaware that that would happen. So they were confused when someone would call and tell them they had to have a colonoscopy done. So if we can let them know ahead of time that to expect one, if the test is abnormal, that we need to explore it further, will hopefully make them more likely to comply with it later. And then also to increase community clinical linkages that support improved access to CRC screening. So that concludes my presentation. Thank you so much.